Hi, everyone, and welcome to the Donut of Destiny. I'm Claire Johns, FSCCT's Director of Membership. Today, we'll be welcoming a special guest host to the podcast, Dr. Sotirios Evangelou. Sotirios is a consultant cardiologist with Interbalkan Medical Center in Thessaloniki, Greece. In this episode of the Donut of Destiny, Sotirios will be speaking with Dr. Gianluca Pontone. They will be exploring the evolving field of stress cardiac CT perfusion, its clinical applications, technical considerations, and the evidence behind its use. Sotirios and Gianluca, please take it away.
Hello, I'm Dr. Evangelou Sotirios, a consultant cardiologist from Interbalkan Medical Center of Thessaloniki, Greece. And we're going to talk about stress cardiac computed tomography perfusion, along with a pioneer in the field, Professor Gianluca Pontone from Centro Cardiologico of Monzino, Milan, Italy. So, Professor, can you introduce yourself?
Yes, thank you very much, Sotirios. My name is Gianluca Pontone. I am professor of cardiology at University of Milan, and I am director of cardiovascular imaging department in Centro Cardiologico Monzino in Milan.
So, Professor, one of the main indications of cardiac CT remain, of course, the evaluation of the coronary arteries, possible stenosis, and the evaluation of the degree of them. Nowadays, exist several approaches to establish the hemodynamic severity. Regarding dynamic myocardial perfusion, the technique, I must say that first introduced in late 1970s, but never reached a wide adoption, and this mainly due to the inability of scanners to image the entire myocardium in a single acquisition. In our era, acquisition of dynamic stress cardiac CT perfusion is performed on CT scanners with a wide detector that can cover the entire ventricle in one or two acquisitions. It is based on serial CT imaging to measure the inflow of contrast media into the myocardium and therefore calculate absolute measures of myocardial perfusion. During CTP, images are required during the transits of contrast from the coronaries to the myocardium. Because iodinated contrast attenuates X-rays proportional to the concentration of iodine, hypo-attenuated myocardial areas typically represent regions with low blood flow or hypoperfusion. So, Prof, as a known expert upon this, can you degrade this a little bit more?
Thank you, Sotirios. The perfusion, the myocardial perfusion by using computed tomography is a recent technique by using multi-detector computed tomography, thanks to the introduction of the wide coverage scanner. As you mentioned before, technically and theoretically, the evaluation of myocardial perfusion with the computer tomography was already available since some years ago. But the introduction of this new generation scanner make this kind of option feasible in the clinical practice. Indeed, thanks to the dynamic CT perfusion, you can acquire multiple slices in this multiple time point in order to describe the wash-in and wash-out of the contrast agent in rest condition and in stress condition through myocardial wall. This is the basic principle that allows to measure quantitatively myocardial blood flow, mimicking what we do, for example, with the PET, or what we are doing now also with the cardiac magnetic resonance. The dynamic CT perfusion is a very relevant step forward for computed tomography because allow to have a quantitative evaluation of perfusion and not qualitative evaluation. Indeed, before the introduction of dynamic perfusion, it was already possible to study myocardial perfusion by using static approach in which you have a sort of qualitative evaluation where gray is absence of flow, and in case of a presence of a contrast agent, you have a qualitative evaluation of good perfusion. But the main problem of static perfusion is that is qualitative, is too much subjective, and when you have a balanced ischemia, I mean vessel disease, you can have a false negative case. Dynamic perfusion overcome all these conditions, and this is the reason why actually is considered the gold standard in the field of computed tomography to evaluate myocardial perfusion.
So at this point, I would like to highlight that myocardial stress CTP uses only vasodilator stress agents at present, since both exercise and dobutamine are not considered options due to practical reasons, and of course high heart rates that would preclude diagnostic imaging. Currently, we are using vasodilators such as dipyridamole, adenosine, and regadenoson. So, Gianluca, would you like to add more information about them? And what would be your personal opinion about the use of the one over the other?
Yes, in general, the stress test, also with the other imaging modality, was performed for a long period with dobutamine or adenosine. Dobutamine is usually one of the preferred stressor, mainly in the field or in the context of echocardiography, because of course the temporal resolution of echocardiography allow to evaluate wall motion abnormality even in the presence of high heart rate. Of course, we cannot transfer the use of the butamine stress test in the context of computed tomography because the temporal resolution of computed tomography, even with the most recent scanner, is not comparable with the temporal resolution of echocardiography. And when you use the butamine as a stressor, the increase of the heart rate does not allow to have good image quality of the myocardium and therefore is not suitable for a good evaluation of the stress of the myocardial performance under stress condition. So the CT perfusion have used for a long period just vasodilatator. And the preliminary experience were done mainly in the literature with adenosine or with dipyridamole. The adenosine has a lot of point of strength because it has a very short half-life, so very low risk for side effect. But considering the short half-life of the adenosine, sometimes it's a bit complicated to perform stress CT perfusion because you need to have two contemporary vein access. Indeed, you have to inject at the same time adenosine as a stressor and contrast agent at the end of the infusion of adenosine in order to evaluate myocardial perfusion. This, of course, is not comfortable for the patient, and therefore it has a sort of restriction from this point of view. The additional point that we have to consider is that adenosine is extremely influenced by some other substances, such as, for example, caffeine, tea, and chocolate, for example. These are all antagonists of the adenosine, and you can reduce if the patient does not respect the restriction before the test, can reduce the sensitivity of the test. More recently, it was introduced the regadenoson. Regadenoson is very selective on A2 receptor for adenosine, and therefore it is selective for vasodilatation of the coronary arteries. There is no effect, for example, on the lung. And this is very useful because it is not basically contraindicated in patients with lung disease. More important, the half-life is longer, and the interaction with the other foods, such as, for example, caffeine or tea, is absolutely limited as compared to the adenosine. And this is the reason why the community of doctor involved in the perfusion program are strongly shifting in favor of regadenoson rather than to continue to use adenosine.
Perfect. And speaking about medications, what about this little debate upon the use of beta blockers and nitro? What would you recommend as a standard of practice from your point of view, of course?
Yes, this is a very relevant point of discussion in the field of stress CT perfusion. Everybody knows indeed that when we have to evaluate and to study the coronary artery anatomy, we need to have a good control of the heart rate. Indeed, we use beta blockade before the acquisition, and it is also very important to have a good vasodilatation of the coronary arteries by using nitrates. The main problem is that both nitrates and beta blockade are anti-ischemic drugs, and therefore, when we acquire the CT under stress condition, it is basically we protect the myocardium against ischemia thanks to the use of nitro and beta blockade. And one of the concerns of this is that potentially we can have a reduction of the sensitivity. However, there are some data suggest that have compared the accuracy of stress CT perfusion. One is from our center as well, in which we compare the performance of CT perfusion in patients in which these drugs were used versus not use of these drugs. And we didn't find significant difference in terms of diagnostic accuracy, which is the reason. Regarding to the nitritis, we have to consider that usually we have a pause between rest acquisition and stress acquisition of 15-20 minutes. This allows to have the washout, quite complete washout of nitritis. Regarding to the beta blockade, we have to consider that the mechanism that there is behind ischemia when we use vasodilators such as regadenoson is the still phenomenon, and therefore the impact of heart rate in oxygen consumption is just limited in this setting, and therefore the influence of the sensitivity of the test is negligible. So, in our opinion, basically the use of these two drugs has no huge influence on the performance of the test.
Very nice. I must say that it is well known that coronary CTA alone has a very high negative predictive value as to exclude myocardial ischemia in the presence of no coronary artery disease or non-obstructive stenosis. Therefore, stress cardiac CT can be useful in cases such as in the presence of stenosis with unknown hemodynamic significance, high calcium score, or presence of coronary stents. So, Professor, what can we expect from stress CTP in terms of sensitivity and the specificity?
Yes, now regarding to the sensitivity and the specificity of the stress CT perfusion, there are already a lot of data comparing this technique versus other imaging modality, for example, SPECT or PET or STRESS-MR, but also versus invasive evaluation, including just cath lab or cath lab plus FFR plus IMR. For example, from our hospital, we published some years ago the perfection study. The perfection study was a prospective study in which we compared both static and dynamic CTP versus invasive FFR. And what we found it was in diagnostic accuracy, sensitivity and specificity higher than 95%. Of note, in this study, we have just included the patient at intermediate to high risk for coronary artery disease. And this means that this population had a challenging anatomy with severe calcification, eventually with stent, and so on. And for this reason, to show an accuracy over than 85% in this challenging setting from anatomical point of view, allow to define this test as a very robust functional test. What I think is that basically the integration of perfusion with CTA is the perfect combination of anatomical evaluation and functional evaluation of coronary artery disease. In this way, we can use the high sensitivity of the anatomy and the good specificity of the perfusion in order to have the perfect combination.
Mm-hmm. So you're talking about studies that validated stress CTP. There are other studies, and what can we expect more to come in the near future?
Yes, what it is expected is a study about the cost effectiveness of CT perfusion, because what we know is that this test is accurate, but we need also to demonstrate that its cost effectiveness as compared to the standard of care, because we have a huge portfolio of stress tests on the ground, including PET, including STEMR, stress echo, and so on. So the question is, okay, we have a new test, but this test provide at least a non-inferiority or even an additional value to the standard of care. At the moment, there is a big randomized trial. To the best of my knowledge, is the only ongoing trial in this field that is the CT CTP Pro study led by the Centro Cardiologico Monzino. Is a multi-center prospective randomized trial in which we have randomized 2,000 patients and split it in standard of care, any kind of second level stress test versus CTA plus CT perfusion. And we compare the two arms in terms of cost effectiveness. The study is very close to the end of the enrollment, and then I take in account to provide 1 year follow-up about next year. I believe that we can have from this kind of trial new insight and very relevant information about the economical sustainability and cost effectiveness of this new emerging technique.
So, regarding your vast experience upon that, what do you believe are the main strengths and limitations of this technique?
The strength, of course, is to complete a puzzle of information in order to add the functional information on top of the anatomy. And we know that actually both information are relevant in the clinical decision-making process for a patient with ischemic heart disease. Regarding to the limitation, basically you can do perfusion, but if you have the right technology is high-tech CT scanner. You cannot do perfusion and robust perfusion with standard technology such as a 64 scanner or similar scanner. So one limitation is to have the appropriate technology that sometimes is not quite cheap. The second aspect is that you need a good and robust training curve, especially in static, but also in dynamic, because as for any kind of test, the human interpretation of the complex puzzle of myocardial blood flow distribution in the myocardium is not so easy. And therefore, high volume of cases and a continuous comparison of your findings with invasive evaluation are the base of a good learning curve in the context of CT perfusion.
So, Professor, after properly image acquisition follows the post-processing. What would be an accepted time of evaluating and reporting a stress CTP, and some practical tips and tricks also for a structural report?
Yeah, regarding to the post-processing, at the moment there are some dedicated software for post-processing of the stress CT perfusion, despite the portfolio of software is quite limited. The post-processing is a bit time-consuming, especially because you have to manage a huge number of images with the software. So there is a bit of time that is necessary just to perform the sampling of the images acquired during the stress. And therefore, you need at least for the evaluation 15-20 minutes. It's not an immediate test. I mean dynamic CT perfusion. Some tips and tricks is about the evaluation and interpretation of myocardium of the ischemia. What I mean, when you have, for example, a myocardial ischemia, what you can see is multiple value of myocardial blood flow with a different distribution inside the myocardial segment. Of course, I don't suggest to use the lowest value measured of myocardial blood flow because this could be influenced by the image noise of the dataset. What is important is to calculate the mean value of the myocardial blood flow of the entire myocardial segment in order to understand if we are close to the ischemic threshold that actually is quantified in about 100 milligram for 100 milliliter for 100 milligram for minute. It's important to have multiple sample and multiple measurement of myocardial blood flow, and at the end you have to put all this information together in order to give the right interpretation.
So, as I personally started a stress CTP service at my institution, and I dare to say with very encouraging results that are at the same line as the main studies, Gianluca. What is your principal advice to one starting implementing this intriguing imaging technique in everyday clinical practice?
Yes, the first effort that you have to do at the beginning is to to have a comparative internal study in order to check the robustness of your protocol. So at the beginning, I suggest to do the perfusion in patients with already scheduled invasive coronary angiography, in which invasive evaluation with both IFFR and IMR is performed. Because you need to have a certain number of patients, 30, 40 patients, in the best scenario, also 50 patients, in which you need to have an head-to-head comparison with invasive evaluation, because in this way the learning curve goes up. After this preliminary phase in which you have head-to-head comparison, then you can start with the real patient, and I suggest to train the patient to have the appropriate breath during the scan. One of the main problems in terms of image quality is the image noise that is derived by breathing of the patient. As you know, the acquisition is quite long, is 30-40 seconds. It's impossible to have the apnea during the entire acquisition. So usually the CT perfusion has to be performed with the patient breathing. But you need to train very well the patient in order to have a small breathing, because otherwise this generates image noise and the post-processing became not feasible. So just to recap, comparative experience with invasive evaluation, and second, good training of patient to be in the best condition in order to have the best image quality.
So, Professor, thank you very much for this insightful meeting, and I must say that those are very interesting and useful things that you shared with us today. Thank you once again, Professor.
Thank you very much for this interview.
That brings us to the end of today's episode. A sincere thank you to Dr. Sotirios and Pontone for sharing their knowledge and experience with us. Stress cardiac CT perfusion is proving to be a valuable tool in the right clinical setting, and it's clear that both the technology and its applications will continue to grow. Thanks for listening, and we hope you'll join us next time.